Thank you very much. My today's talk is on diabetes prevention, and I'll be showing you some data. Thank you very much, Bansi Bhai, Pratap Bhai, Sanjeev, Rutul, Piyush, Dr. Shah, Dr. Parikshit, Dr. Vyas, Dr. Shishil Patel, and Vipul and Malay for inviting me here. And on behalf of Hello Diabetes Academia, I would like to invite all of you to join me for 6th, 7th and 8th June at Nagpur. I don't have any conflict of interest for this particular session. We'll have discussion on the rationales of diabetes prevention. Why should we need prevention? Some strategies to see how do we screen pre-diabetes and who should be screened, which test should be done, describe the results of DPP, Diabetes Prevention Program, outcome studies and ACTOS, and some practical tips. So why should we prevent diabetes? I feel everyone knows now this is IDF data. Just a few days from now it was published. And India we still in the second in the list. China is on the as number 1, but the numbers are going up and up. And then when it comes to the top 10 people undiagnosed, almost 43%. That means almost 50% of your population, every second person still undiagnosed here. When it comes to the burden of type 1 diabetes, again we are supposed to be on number 2 with around 9,40,000 patients, which is going to might increase by which is almost 3 lakhs number of children less than 20 years. So it's a big number and big load we have when it comes to type 1 diabetes. Southeast Asia, it is expected that next 15-20 years we will have almost 73% growth. Important, it is not just pre-diabetes, it is not just diabetes, it is dysglycemia and associated complication. When we talk about prevention, it should not be just diabetes, it should be prevention of normal person to develop pre-diabetes or pre-diabetes to not to develop diabetes. If you have diabetes, then you have a primary prevention, a secondary prevention of not developing any complication, and if someone has some complication, it should not be another complication or the second MI if he already has first MI. So what is the burden of the complication of diabetes? 60% higher versus non-diabetics, cardiovascular disease, almost 54% higher of number of strokes, 73% migraine infarction, and 84% higher risk of having heart failure. From IDF, the data, this atlas, it says that people with type 2 diabetes are at high risk of developing heart attack. They have 56% higher risk of having dementia. The earlier someone develops type 2 diabetes, higher is the risk of developing dementia in the later life. Close to 1 in 4 adults have diabetes-related retinopathy, and almost more than 1 in 10% may have diabetes-related retinopathy-related blindness. Now, so diagnostic criteria, I am not going to go in detail of it, but this is how you are supposed to diagnose. You have all the possible tools available. You can simply go for fasting blood glucose more than 126. You can diagnose that as diabetes. 100 to 125 could be pre-diabetes in one ADA recommendation. IDF says 110 to 125, so that's the only difference. And more than 200 after glucose or post-meal more than 200 random blood glucose can be diagnosed. And of course HbA1c criteria you are all aware of. Less than 5.7, normal 5.7 to 6.4 is pre-diabetes, more than 6.5 is diabetes. So this time bomb was there 2012, almost 20 years from now, and it still exists the same and gradually increasing. Now, Southeast Asia, 1 in 10 adults have diabetes, 1 in 7 adults worldwide is from India, and number of adults increasing day by day. Now, if you just go through the natural course of the disease, you will understand the scope of your work as a clinician. It starts from the pre-diabetes of impaired glucose tolerance, where these people have insulin resistance, hyperinsulinemia, dyslipidemia. You need to address this. And these patients with pre-diabetes, maybe IFG or IGT, are more likely to have atherosclerotic phenomena. So macrovascular disease is higher in pre-diabetes versus normoglycemic individuals. That means once you have pre-diabetes, then you are more likely to have migraine infarction and stroke versus those who are non-diabetics. So the risk gets further escalated once you develop frank diabetes. So don't ignore pre-diabetes. Onset of diabetes occurs, and then once you develop fasting more than 126 or post glucose more than 200, then you sets in the microangiopathy. So macroangiopathy or big vessel disease comes much earlier than the microangiopathy, which sets in after the development of the diabetes, and then you have a disability, and ultimately you have blindness, renal impairment, coronary artery disease, amputation, and death. So this is a natural course of a type 2 diabetes which starts much earlier, and we have as a clinician, we have a responsibility, the social responsibility of diagnosing them early, treating them early, try to prevent them at max whatever you can prevent with whatever gadgets you have. So how do we identify these pre-diabetes? We have wonderful recommendation globally, but we also have data from Dr. Mohan's group, and what it says, combination of 5 risk factors could be explained to almost 81% of the incident diabetes. That means you will be almost 81% of the patient will be diagnosed if you just follow these 5 things: obesity, physical inactivity, more than 3 hours sitting, or you are watching TV for more than 1 hour per day, poor dietary habits, hypertriglyceridemia, low HDL. If you have these 5 risk factors, you are likely to develop diabetes almost 81% cases. You also have IDRS score, you have age, waist circumference, physical inactivity, family history. And if your score is more than 60, very high risk, 30 to 50, moderate risk, less than 30, low risk. I put myself, my scoring was done, I come to the second, the moderate risk of this. Unfortunately, I'm not as lucky as low risk here. So once you have pre-diabetes, diabetes, screening is important. How do we screen them? Screening of risk has to be, for risk of pre-diabetes and T2 diabetes is important. And we say that anyone who is more than 35 years of age should be done. We should go for screening. Now, the recent recommendation, if you remember, when we were students, we used to say after 50 you should do it. Then came the figure of 40, which remained for quite a long period. But this last 2 years, they have come out with 35. And I personally recommend, and most of the experts in the group who are sitting here, they will say if you have a positive family history, if you have a high risk factor, after 30 you should start screening for diabetes. Then if it is negative for the first time, then you can do it every 3 years, which is also reasonable. Which is the method you should do it? Simple OGTT or GHB, anything you can follow. Now, risk-based screening for pre-diabetes and diabetes should be considered after the onset of even puberty. This is a recent recommendation from American Diabetes Association. After 10 years of age, whichever comes earlier, if puberty comes, either that or 10 years of age, in children and adolescents with overweight, so those who have more than 85 percentile of weight, or obesity more than 95 percentile, and who have one or more risk factor for diabetes, they should, the screening of pre-diabetes and diabetes now should start from puberty and not now 30 even. So consider the screening even patients who are on steroids, statins, thiazide, diuretics, HIV medication, second generation antipsychotic drugs. Then you have, if you have second generation, important. If someone is on second generation antipsychotic medication, screening for pre-diabetes and diabetes at the baseline should be done and repeat after 12 to 16 weeks. That means 3 to 4 months. You have to repeat it after the medication initiation and thereafter once in a year. Those who are on ART, the antiretrovirus therapy, even in those patients you should have a baseline, and 3 to 6 months you should go on doing their blood glucose. One should also, very few of us know that we also have a pre-diabetes state in type 1 diabetes. Though it's a very brief period, because diabetes is an insidious, type 1 diabetes is an insidious disease. It suddenly comes. But they also come with the stage 1 and stage 2 before they develop the frank type 1 diabetes, frank overt hyperglycemia and symptomatic. So first is a phase of autoimmunity, normoglycemia, pre-symptomatic, and they will have multiple ILS and LH antibodies. But fasting blood glucose HbA1c is normal. Then they have stage 2, again autoimmunity is there, dysglycemia might be there, pre-symptomatic phase, but it will be of the pre-diabetes range. That means fasting is between 100 to 125 or 2 hours between 140 to 199. So anyone who has GAD antibody positive, insulin antibodies positive, islet cell antibody positive, anyone, even one antibody positive with some small amount of dysglycemia should be considered as stage 2 for type 1 if other parameters comes. So there is a treatment for pre-diabetes, type 1 diabetes, which has recently been approved. I'll come to this little later. Those babies who are born to a GDM mother, strong family history, ethnicity, all these patients should be screened. Now, prevention or delay of diabetes and associated comorbidities. Now, lifestyle changes. Now, do we have a data? Okay, Dr. Gupta, you have come here and you are talking about pre-diabetes. Tell us the data, whether the interventions have really worked. So we have a wonderful, like you have DCCT trial for type 1 diabetes, UK PDS trial for type 2 diabetes, that's all efficacy and complication and intensive versus conventional therapy. Now you have a data for lifestyle modification versus metformin for prevention of development of diabetes and pre-diabetes. So lifestyle change, this is a DPP program, diabetes prevention program, where lifestyle changes and the treatment with metformin both have reduced the incidence of diabetes in people who are at high risk. The lifestyle intervention was more effective than metformin. So reduction of the development of the risk reduction of development of diabetes was more almost 60% with lifestyle modification in 3 years versus 31% metformin. So the lifestyle modification is more effective than metformin. And then important is that these patients of DPP have been further followed for 10 years. That's called a DPP-O trial, DPP outcome trial. And their interpretation again during follow-up incidence in the placebo and metformin group failed to equal those in the former lifestyle group. But the cumulative incidence of diabetes remained lowest in the lifestyle group. That means lifestyle has still worked even after 10 years of the trial. And important now you have a 15 years follow-up data that what it has interpreted that the lifestyle intervention or metformin significantly reduced diabetes development even over 15 years, and there was no, but unfortunately there was no difference in the prevalence of microangiopathy significantly. So this is a wonderful summary of the DPP-4 trial. You have a lifestyle, metformin and placebo arm. This is the first 2.5, 3 years, then you have a 10 years, and then you have up to 18 years. So total 18 years if you include the first 3 years. And you just see the baseline 94 weight, so lifestyle modification, weight loss was seen. Once they are out of the trial after 2.5, 3 years, they started gaining weight. But then thereafter, if you see the development of diabetes remain lower versus the placebo with the upper arm. So they were exposed to the therapy, intervention, lifestyle metformin, and they have saved themselves from developing diabetes to a large extent, even if they are not taking metformin, even if they are not taking lifestyle modification. So this is what versus the placebo. Similarly, this is the diabetes development. If you see the conversion rate earlier was much more higher. The development of diabetes was lowest in lifestyle modification versus metformin then versus placebo. After 10 years, it went to 44, 48 and 55, and then it further increased to 52, 55. So almost similar. That means if you give some intervention in the beginning, so you also have a legacy effect of lifestyle modification, like what you talk about legacy effect of good glycemic control in the early stage. That's another message to all of us. DPP-OS trial, neither lifestyle nor metformin was associated with reduced microangiopathies. The prevention delay of the diabetes development was associated with 28% lower frequency of small vessel disease. In women with lifestyle intervention reduced microangiopathy by around 22%. And importantly, those women who had past history of GDM, they have been benefited more with metformin versus the other women. Then the pioglitazone, this is the ACT-NOT trial where pioglitazone was used for prevention of diabetes, and see the figure. 72% reduction in the development of diabetes with pioglitazone. Of course, there was it at the cost of weight gain and edema. So now do we have an Indian trial? So Make in India trial, we have IDP, Indian Diabetes Prevention Program, IDPP program, and they have again shown that lifestyle modification and metformin both can prevent type 2 diabetes to around 38-39%, and this is a trial from Dr. V. Mohan's group. Then you also have DCLIP trial. There is around 580 patients. They have IGTs and IFG patient as well as IGT plus IFG patient. Both of them have again lifestyle modification and the metformin and the another arm. 500 milligram twice was given, and let us see what is the outcome. The conclusion from this study is cumulative incidence of type diabetes over 3 years was 34% in the control group, while 25% in the intervention group. So relative risk reduction was around 32% again here. Then the pragmatic, this is the pragmatic, okay, now we have a era of technology where Amit is sitting here and Rakesh and all technology people are here in this hall. Now, do we have any role of life, some modern technology? So this is here they have used some mobile technology for having a better compliance and lifestyle modification. Here again they have showed that the mobile phone messaging is an effective and acceptable method to deliver advice and support towards the lifestyle modification, and to which can also help us to prevent the development of diabetes. The relative risk reduction almost 36%. Overall recommendation in people with pre-diabetes, monitor for the development of type 2 diabetes at least once in a year. Those who are pre-symptomatic type 1 diabetes, we should monitor HbA1c 6 months after the diagnosis of stage 1 or stage 2 type 1, and then sub 75 gram OGTT annually has to be done. Then you have the lifestyle behavior changes in prevention. So you have to see that weight reduction at least 7% of initial body weight will certainly help you to postpone the disease, along with the 150 minutes walk. Now they say 200 minutes walk or 250 minutes walk is being recommended. Different kinds of diet you have. Intermittent fasting is one which is being followed in our, and low carb diet. This has been now recommended that may have some benefit in the prevention. LSM programs for diabetes prevention such as DPP should be offered to those who are at high risk. And of course, sometimes you can use technology in this. Metformin for prevention of should be considered people for prevention of diabetes in pre-diabetes, and women with past history of GDM again are benefited. But we have to also take care of the B12 deficiency with chronic use of this. Now, pre-diabetes associated with high risk of cardiovascular disease, so maybe statin therapy, glucose should also be monitored. It is recommended that the statin be avoided or discontinued. Should not be discontinued. If you have now statin can cause diabetes, and this has caused big phobia. People will come to you, oh, you have given me statin, I might develop diabetes. Now that debate is almost closed. There is no controversy in this. They have seen the risk versus the risk of diabetes versus the benefit, and benefit is much higher than the risk of developing hyperglycemia. That is why statin can be given. People with history of stroke and evidence of insulin resistance and pre-diabetes, if pioglitazone is not contraindicated, can be given. Now for stage 1 and stage 2 of type 1 diabetes, there is a drug called as teplizumab, which is again just shown delay in the development of type 1 diabetes. Last but not the least, in 1 minute, is about the pregnancy. Pregnancy is one area where we can certainly think of primordial prevention. And that primordial prevention is epigenetic changes which might occur in the developing fetus if the metabolic milieu is not healthy. So if you keep good glycemic, or if you diagnose even a smallest part of the hyperglycemia, simplest form of the hyperglycemia more than 120 in the early stage, and treat them, possibly we will save these baby of developing diabetes in their adulthood. And that's why Professor Shaya has come out with the notion that if you want that after 20 years or 30 years you should not have a single case of diabetes, then you have to focus on pregnancy. There is a strong correlation between the fetal adiposity and the insulin resistance, as well as maternal pre-gravida BMI and fetal insulin resistance. Cod leptin had a significant correlation with fetal insulin resistance. So this is how intrauterine exposure to maternal diabetes is associated with higher adiposity and insulin resistance, clustering cardiovascular risk markers in Indian children. So we have to be now focusing pregnancy more often. Sleep duration, breastfeeding duration, rate of weight gain in the infant, all these are the risk factors. So maternal obesity, nutrition during pregnancy, early growth pattern, breastfeeding and epigenetic programming, these are other potential areas where we should be working for the prevention of diabetes in the future generation. So final key to prevent type 2 diabetes is eat less, walk more, sleep well, stay lean, and smile. I feel this is a notion comes from Dr. Padma Shri, Dr. Shashank Joshi, and I picked up from him. And many of the slides have been picked up from Dr. Sundar Mudliar. So with this, I stop here. I once again invite you for the Hello Diabetes Academia, which is on 6th, 7th and 8th June at Nagpur. And this is my last slide, and I have another 30 seconds with the permission of chairperson, that one more important thing in the society all you can do, and which we are doing it since 30 years. I am showing this slide. This is my last slide every time, that instead of cutting a cake, instead of cutting cookies, instead of getting that hydrogenated fat, which is atherogenic to your endothelium, start cutting the fruit. So cut the fruit and not the cake to celebrate any occasion. Maybe it is your birthday. Maybe it is your anniversary. Maybe you are celebrating the success of Diabetica. You should not be cutting the cake. Rather, you cut the papaya, cut the watermelon, and celebrate your occasion. With this, I stop here. Thank you very much for your patience, Sunil.